Okay. All right. Well, I think we're right at the top of the hour, so we'll go ahead and get started. Good morning, good afternoon, good evening, everywhere in the world, wherever you may be. Welcome to our second live session in our Global Spine Surgery Conference. Really do appreciate you tuning in and spending your Saturday with us. Today we have a really fantastic set of case presentations, so let's just jump right in. Today we'll be talking about endoscopic spine surgery. This is the second of 3 sessions. Last week we did traumatic spinopelvic dissociation. That recording is available for free on YouTube for any of you who want to catch up. And then next week on Saturday, we'll be moving on to pot spine and complex spine infections, which should also be a great conversation. So just as a reminder to all of you on the line, Zoom today is enabled to allow for translated captions. So if English is not your first language, please do follow these instructions to click on the closed captions and enable closed captioning in whichever language you prefer. Course objectives are the same every time we run these courses, but I think it's always worthwhile to go over them. First and foremost, to enhance our participants' knowledge. That's our most important objective, of course. Second, we want to facilitate this international collaboration and dialogue around the world on important topics related to spine care, especially in resource-limited settings. And third, we want to motivate and support the next generation of surgeons, the young surgeons, the trainees out there who will be serving people all around the world. So my name is Dr. Kiran Agarwal-Harding. I'm the director of the Harvard Global Orthopaedics Collaborative, and it's my pleasure to chair this course and help with the organization. And I'll really be handing it over to Dr. Amakiri. He's an orthopedic resident in our program here at Harvard, and Dr. Enrique, who's an orthopedic surgeon from Mexico, who will be moderating today's session. Big shout out to all of our HGOC and SONA organizing team members. Without their incredible contributions, none of this would be possible. So thank you so much to everybody on the HGOC and SONA team for everything that you've done to organize today's conference. Really grateful for your contributions. We have some fantastic case presentations today representing Pakistan and Nepal. So we've got Dr. Zubair Khalid from Pakistan, Dr. Bishnu Babu Thapa from Nepal, and Dr. Umair Ahmed from Lahore. Thank you guys so much for your case presentations. And we also have a fantastic set of faculty with us today. So Dr. Rizwan Akram, also representing Pakistan, Dr. Rafael Sugino, representing Brazil, and Dr. Jason Pittman, representing my own home institution here at Harvard and Beth Israel Deaconess. So thanks so much, everybody, for being part of this today. So that concludes my introduction, and without further ado, we'll go straight into the first case presentation by Dr. Zubair Khalid. So Dr. Zubair, whenever you're ready, go ahead.
Yes. Is my screen visible to us?
Yes, it looks great.
I'm Dr. Zubair Khalid, working as spine fellow in the Department of Orthopaedics and Spine, Gurukul Trust Teaching Hospital. This is my home, my center. The first case which was presented by me is the L45 spinal stenosis. The age of the patient at the surgery is 44 years male with the history of the diabetes, the comorbids of the diabetic mellitus and hypertension. Patient has a bilateral low limb radiating pain, which was treated by conservatively, and this failed treatment of conservative and the injectable treatment. A patient was presented with a chief complaint of the bilateral low limb radiating to the both low limbs for the 1 year, more on the right side. Patient has a numbness of the both feet with the neurological claudication distance is reaching up to the 50 meters. Patient has a VAS score of the lower limb is 9 and osteoid disability index scoring is 70. The patient bowel bladder was intact with no periaral numbness. On the examination, the right side straight leg raise test is 50 degree and for the left side is 60. On neurological examination, patient has a right side L5 and L4 power is 3/5 and the left side the power L5 and L4 myotome is 4/5. And patients have decreased sensations in the L4 and 5 dermatome. We advise the X-rays with the flexion and extension, which shows there is no instability. And the MRI, which shows there is a spinal stenosis at the level of L4 and L5 region, with the paracentral, central, and bilateral foraminal stenosis at this point. And the Shizas classification for this is grade C. Our diagnosis is L4-5 spinal central stenosis and foraminal stenosis with no spinal instability. So we proceed with the procedure of the unilateral amniotomy with bilateral decompression with UBE technique of L4 and 5 from the left side. This is the marking of the level, and the intra-op picture is showing the cranial extent and cranial lamina of L4 and caudal lamina of L5 and the ligamentum flavum. And this after the surgery decompression, there's the both sides traversing roots and thecal sac was visible with no signs or with no hypertrophic ligament flavum is present now at that time. This is the patient follow-up video at the 0 post-op day with the VAS of both lower limbs is 2. And this is the follow-up video of the patient after 12 weeks. With the ODA scoring is decreasing from the 70 to the 30, and the VAS is 0 of the both lower limbs. And the patient is moving, and this neurological distance is now increased. Thank you.
Thank you, Zubair. Do you mind going back to your initial preoperative X-rays and imaging, just for the purposes?
Yes, sir.
Thanks. I'll hand it over to you, Ike.
Hi, Dr. Zubair, and thank you for joining us and for the presentation.
Thank you.
You know, in the core curriculum, we talked a lot about, once you figure out what the pathology is and what you need to treat, the endoscopy is just one of the tools that we have to treat the pathologies that are known to us. Can you kind of walk through your thought process on why you decided to use endoscopic technique, and then why biportal versus uniportal, and then I guess the last part would be why you went into interlaminar versus transforaminal.
Yeah, the one of the main reason is this patient has there's no instability on the dynamic X-rays, and the patient has a history of the neurological claudication with more prominent symptoms on the right side. If we see the MRI, there is the hypertrophic ligament flavum which presses at the L4-5 level, and there's more stenosis at the level at the paracentral and the right side L5 foramen. And as the patient has no instability, so I will not go to any fusion technique. And with the endoscopic technique, with the biportal endoscopic, there is a great freedom of the movements of the both hands and working channels and the wing portal. And for this, as the patient has more symptoms on the right side, I decide to go from the left side with this interlaminar approach of UB, we can able to decompress of the right side foramina very good as from the left side if we go with as compared to the uniportal endoscopic techniques.
Great case, Dr. Khalid. I was wondering how do you think, or how does he behaves on that L5S1 disc? Do you expect any changes after your surgery?
So there is a chances of the segmental disease after the surgeries, but as we have very small bone resection at this region with the minimal invasive techniques, so chances of instability and the end plate changes are less as compared to we do in the open techniques.
Is that true? Like if you do an endoscopic technique with a minimally invasive approach, there's less of a chance of degeneration of the disc? Jason, maybe you can comment on
Yes.
that.
Not really. Well, at least the literature is very clear on the risk of adjacent segment and fusion. But in decompression techniques, the thought is that you're not grossly changing the mechanics of the spine, so you're not going to alter or increase the risk of adjacent segment degeneration. The advantage of the endoscopic techniques over, say, an open midline laminectomy is the surgical footprint and not disrupting the paraspinal musculature, which may increase the rate of degeneration because you're denervating part of the paraspinal supports, you're causing scar tissue, which is going to alter the mechanics of the spine across that segment. But I like to tell my patients, we're going to address the problem that's in front of us today. We don't know how your spine will age around what we do, and there may very well be future surgeries for you. We just don't know.
I do have found, like, I have less cases of adjacent disease with endoscopic surgery, even more for stenosis. And I think that's been a great advantage for these herniations. I think, yeah, we can expand the life of that disc, the adjacent disc, and probably in a lot of cases we can save more surgeries.
And the hope with the endoscopy is that you can do more non-fusion surgery because it opens the door to certain decompressions that with open techniques would require a facetectomy or, things that put you in a fusion pathway. And so the flexibility that endoscopy gives you is hopefully fusion sparing.
Yeah, once it's fused, there's no going back. You can only keep fusing, right? The next levels.
Rafael, I see you. Do you have a comment that you wanted to make?
Yeah, I like a lot the comment of Jason saying that with endoscopy you have less footprint on the soft tissues, you preserve more anatomy, and like Enrique said, when you fuse a segment, the problem goes to the adjacent levels, so they become now a problem. And if it's even with fusion, it's worse because you have a leverage that is with a higher stress over adjacent segments, so it could increase so by saying that endoscopy might be better for adjacent segments, but like Jason said, we are addressing the problem that is annoying the patient at the moment. We're not preventing any other stuff. But one thing I would like to add to this conversation is when we do a technique, it's not only saying that you're doing the technique. It's not saying you did endoscopy surgery, because I've seen a lot of people doing endoscopy surgery with a lot of facet amputation. They're not preserving the anatomy. They're doing the technique with sometimes too aggressive. So when doing the surgery, it's important also to understand how we do it, and because it has consequences from what we do. If you are too aggressive, maybe to the disc or to the facet, you can also lead to instability. That's one thing I would like to add, and also compliment, because I like a lot this way of thinking that we're preserving more the anatomy to the natural. Yeah.
That's a great point, Rafael. It's just because it's a small incision and minimally invasive approach doesn't mean you can't do a lot of damage once the instruments are inside. That's a really great teaching point. Dr. Rizwan, since you're at the same hospital as Dr. Khalid here, perhaps you were involved in this case as well. I'm wondering if you have any teaching points from this you'd like to share.
Uh, uh, Actually, I was thinking on it as Enrique was asking that what about the L5S1? So first of all, the principle remains the same, that which the one level which was symptomatic. So we uh, chose to operate like in open surgeries. You operate on a symptomatic disc and do not go uh, once in doing all work done. I think that was the at the time of surgery we chose to went in for the symptomatic level. And secondly, yes, I agree that it's not minimal invasive unless you respect the anatomy and preserve the facets. If you go in and shave off all the bones and you just disturb the joints, yes, it will surely will be unstable spine later on. And likewise, if you remove too much disk, that ends up into it's empty disk space, and it grows into a unstable level, and then you have to fix it.
Yeah, and if you go to social media, you can see a lot of people like showing cases, even in like spine meetings, like facet amputation, sometimes like disc destroyed. It's pretty common to see that, especially in social media.
So one of my question is this case.
Yeah, that's I think
In
that's a
such
good
cases,
test.
in such cases where there is an hypertrophic ligament phlegm, the main cause of the stenosis. In such cases, we have to go into the disc space or not to remove the disc also.
Any of the faculty have a comment on that?
When I have stenosis cases, I under the disc seems like no protruded, and stenosis comes more from the ligamentum flavum. I only resect the flavum. I don't see any case on damaging that disc, which is what I was thinking now that Dr. Rizwan was talking. All these cases are like more, you don't have like a formula. It's all, every case seems to be different, and you have to remove a little bit more, a little bit less. So I was wondering what the workup you do for any one of your patients once you are deciding or think about endoscopy. What studies do you ask for?
We rely first of all the clinical examination. This is the most important thing, and then you relate your examination with the images. You have a standing x-rays or a flexion extension view. And if we are very much confused for any two levels, or we are deciding for that, you can go for nerve conduction, but usually it's not important and not necessary. If you examine the patient clinically, you decide, and your findings are very much matching with the images. So this is what I do.
I'd like to comment on one of the questions
Yes.
that Ike asked, because one of the big debates in endoscopy is uniportal versus biportal techniques.
Okay.
And a lot of times it is dependent on the resources you have available in your institution. Some of it is how were you trained. Other times it's cost. At least that's a big concern for us in the US, is cost. And there is a big cost difference between uniportal and biportal techniques as far as the disposables and the single-use instruments for each of the techniques. Ultimately, you just have to ask, can I achieve the end result with the tool in my hand? And it doesn't matter which of the two techniques you use, as long as you're able to achieve the surgery that's in front of you. The argument in favor of the uniportal technique is that it tends to be interlaminar rather than what I will call translaminar with biportal, where you actually do a hemilaminectomy. And you saw a very nice central decompression in this case with the biportal technique. And the biportal technique allows you to achieve exactly what you would down a tube, but with an endoscopic footprint. The uniportal technique focuses more on minimal bony disruption and a true resection of the ligamentum flavum. Now, the next question I asked was interlaminar versus transforaminal. I'm not sure that anybody here would go transforaminal in this case because you cannot get an adequate central decompression there. Your transforaminal approach is going to be nice for a paracentral or foraminal disc. Also, some facet hypertrophy, because you can do a little bit of a facetectomy from the transforaminal approach and get a little bit of the lateral recess. But I think in this situation, just about everybody here would go interlaminar.
Thank you for that summary there, Dr. Pittman. Appreciate it. We have a question in the chat. Want to know if the pathology was 2 or 3 levels, would we still be thinking about doing this endoscopically? Has anybody had success doing that, or does that change your algorithm altogether on which, again, tools to use in a toolbox? I guess, what are the limitations to, and are levels of limitation to whether or not you use endoscopic techniques? Dr. Rizwan?
Yeah. I have experience of 3 levels stenosis doing with UBE. It's not bad. It's good. You can do it. And for every level, you have to make 1 portal more. And there are few cases in which we just did using these 2 portals. Like sometimes you land into a wrong level. So we use the same 2 portals for 2 levels, even by jumping technique, and that was also fine. And in that technique, we just at some point we need to use a 30-degree scope. We just change the 0 degree from 0 degree to a 30 degree. So yes, we can do with the UBE for 2 levels, for 3 levels. Yes, we can do that, and it's a safe technique.
Thank you. Dr. Pittman?
Multiple levels. I still am early enough in my endoscopy practice that I look at how long it takes me. And my goal is still patient safety. And it's not to be able to tell them, oh, I can do all this endoscopically. 3 levels, that's open for me at this point in my practice, unless there is an overwhelming comorbidity that I need to minimize by doing something that's not open. Beyond that, 2 levels, I still tend to go down a tube because it takes me half as long as it would endoscopically. And again, it's just, don't forget the patient safety aspect, and time in the OR is safety. And be honest with yourself and where you are in your skill set and your application of this technique.
I agree with the gist. Yes, time matters. Yes, if you are sure you can complete your work in 2.5 hours, that's fine.
Thank you all for the discussion on that.
Thank you for raising the point.
For this first case, Dr. Zubair, we're going to move on to the case number 2.
Yeah, yes, sir. The second case is this L5-S1 prolapse intervertebral disc. The patient presentation at the age of 37 with the pain in the left lower limb, radiating pain with a VAS of the lower limb is 9, with a VAS back is 1. The patient has complained of left lower limb radiating pain for the 6 months, with the complaining of numbness of the dorsum of the foot since 5 days. Pain increases with the walking and the lifting things. Not able to walk since 2 days, and the VAS for the lower limb is 9, and the ODI is 70. The bowel bladder was intact with no perineal numbness. With the right side, SLR is 70 degree and the left side is 40 degree. The right side lower limb power in all myotomes is 5 by 5. On the left side of the EHL is 4 by 5 with a degree sensation in the L5 and S1 dermatome. We advise the patient the X-rays, lumbosacral spine epilateral, which shows there is no instability. We advise the MRI, which shows there's L5S1, that is bulge with the paracentral region more on the left side. Our diagnosis is L5S1 prolapse intervertebral disc with no spinal instability. We proceed with the interlaminar approach for the L5S1 on the left side, UB dissection. This is the marking of the level, and this is the X-ray showing the placement of the tube of the portals. The L5 superior lamina and the S1, the cranial caudal orientation of cranial side of L5 and caudal 4. And of this, the showing the disc which compressing the traversing root, and this is after the dissection. So we remove this, and the patient has a 0 post-operative day. The VAS is almost 2 by 5, 2, and the patient was able to walk properly with no signs of the pain or the radiating pain. The 6-week post-op in the follow-up OPD with the VAS is 0 by 5. However, this patient has some Tenderberg gait, maybe the weakness of the L5 region, and the patient is in the physios of doing the exercise regularly to strengthen the abductor region.
Thank you, Dr. Zubair. If you could go back to the pre-op MRIs. Again, similar question here. You use the interlaminar technique, and I wanted to kind of gauge the crowd, and I guess we can start with Dr. Rizwan again. If you believe that the interlaminar technique was the way to go here, or do you think it's also possible to decompress and perform this procedure with the transperiminal, and then what are the limitations guiding you in one direction or the other?
Yes, thank you, Amakiri. Actually, yes, we are trained more into interlaminar. We started transfemoral with the working channel scope, but the cost was, it was the restraint for us in our country, and we have to shift to UBE. So now, yes, in this case, transforaminal was also an option, exactly, and yes, you can handle it with the interlaminar as well as transforaminal, depending on your expertise and the availability of your gadgets.
Dr. Rafael, you have your comment?
So this is a very good question because we're still debating in Endoscopic Congress. It's like L5S1 foraminal approach is like a very difficult approach, and we face a lot of problems. First of one is anatomy, because you have iliac crest and the weight. So some people try to angulate a little bit more, and some people just repass the iliac crest by doing like a hole in it. And when we do like foraminal approach, and also from my experience, I did some cases, not for intracanal pathologies, but for foraminal pathologies, we have a very high rate of dysesthesia. There is a complication that is very bad. Jason is like kind of bombing his head, because when you face this complication, it's very, very bad for the patient, and it takes like 3 to 4 months. So it's not a good experience even for the doctor, neither for the patient. Yeah, Jason, you can also share your thoughts. So for L5S1, I wouldn't recommend foramen approach.
And Rafael's right. So the other issue, other than the ilium, is how the nerve root drapes across the disc when it exits at 5-1. The nerve root tends to sit lower in the foramen at 5-1. So your traditional approach for transforaminal is into Camden's triangle, and Camden's triangle at 5-1 is very much smaller than it is at the other levels. So everyone here will say one of the hardest parts of this surgery is simply finding where to put your portals. And if you mess up your portal placement, the surgery becomes a nightmare. But if your portal placement is spot on, regardless of technique, the surgery becomes amazingly simple. But this is a great opportunity for biportal or uniportal to come interlaminar and likely over the top, potentially over the top. So approach from the contralateral side, which will give you good access to the foramen. But in the setting of a paracentral disc herniation, you just come down right on it like you would a tube, regardless of uniportal or biportal, and come interlaminar at 5-1.
Mohammed has his hand up.
Yes, I have a question. I just want to know about that. What should be the recommendation in the putting the drain in postoperatively?
Could you ask your question again, Mohammed? I'm sorry, I couldn't hear you.
So my question is, whenever we're doing the UB surgery, what is the indication of putting the drain postoperatively? What is the recommendation?
I think with drains and the biportal technique, I still place a drain after every surgery. The concept there is not for prevention of a hematoma like you would in open surgery, but to allow exit or egress of all the irrigation fluid. But I've also talked to people that have been doing this long enough that they've stopped placing drains because they haven't seen the hypothetical value in reality.
So it's basically the surgeon's choice that whatever he wants, is comfortable with drain or not comfortable with drain. Am I right, sir?
Correct, at least for me. And the drain comes out within an hour or so after surgery, before the patient leaves PACU to go home.
Thank you so much.
I do uniportal surgeries, and I've never placed a drain, and I've never had a problem by not inserting the drain. So that's my experience.
Yeah, even in biportal, what we used to do is that when we stop surgery, we keep the cannula in and let the fluid come out, and I stop the irrigation to see any bleeding point, any active bleeding point. So if you stay for a while, stop the irrigation, you will see whether there is a bleeding or not. And if there is an active bleeding point, you open the irrigation again and then try to stop that bleeding. And most of the time, you will not see any active bleeding. And I do not use drains in my surgery. Thank you.
Another interesting question. Thanks for bringing that up. I guess going back to Dr. Pittman's answer about the drains, is that something that did you start putting drains from an experience that you had, or is it something that you learned throughout your training? And then I guess the same question to Dr. Rizwan and Dr. Rafael.
So for me, it was simply, it's one of the few times I go, yep, that's what I was taught to do, so I do it. And then, I agree that if you are aggressive about letting the fluid, decompress before you close the wound, like leaving the cannula in place, applying just some gentle pressure across the surgical site to express fluid, these are simple things. And my decision to remove the drain, there's no real thought process behind it. It's like, it's been an hour and a half, minimal output, drain can come out. And I think that is ultimately what drives people to just eliminate the drain altogether. And with biportal, it's easy to place a drain because you have the two portals. So you can leave the camera in place and see that you're placing the drain where you think you are. Uniportal, you don't have that luxury necessarily, and you're trying to, put the drain down the working portal and then pull the camera and the cannula and the scope out with the drain still in place. And so it becomes a little bit of a, disaster. So I think the evidence on drain placement is very poor. It's out of a theoretical concern that people do it. And I think that's why a lot of people end up abandoning the drain once they're confident in their own skills.
And by that, Jason, you mean the confidence to be able to prevent bleeding that would need to be drained?
Again, and so the beauty of the uniportal is you do very little bony work. So you don't have the bony bleeding like you do in the biportal. But every case I've ever done down a tube, I have never placed a drain. So the reason for placing the drain in the biportal, in my mind, is again to deal with the irrigation fluid, not the postoperative bleeding. And there's no difference in the irrigation between biportal and uniportal. So why are we placing drains in the biportal world other than a theoretical concern that hasn't really panned out? So it's when you start with, this is how I was taught, it's quote unquote the safest thing to do. And then people get far enough along in their experience and their exposure to the technique, they go, why am I wasting my time?
Gotcha. There's another, just to change the topic a little bit back to this transforaminal comment that you guys had earlier. There's a question from Umair Aziz. If the department is equipped with an endoscopic set, tubular system, microscope, etc., what is the cost limitation equipment to prevent foraminal approach, as mentioned? So I think just questions about cost. And Dr. Rizwan, maybe you can comment on that one, or Dr. Rafael?
Yeah. Actually, for transforaminal, it's a different set of scope than the interlaminar. It's a separate set that you use for a transforaminal. The caissons and things are longer than the scope of a interlaminar. So one difference is that you need a separate set for that. And secondly, overall, all the working portal, uniportal endoscopies, they have things which are disposable, and patient has to bear the cost of that. So my shift was due to the cost of per patient, which patient has to bear.
That's very clear explanation. Thanks, Rizwan. The last comment here before we move on to the next case is about perioperative antibiotics, giving antibiotics before the case, giving antibiotics after, and for how long. Just quickly across the panel, any thoughts on that?
Just routine preoperative antibiotics for me, no postoperative antibiotics.
Yeah, the same.
I only give post-operative antibiotics to diabetic patients, just because sometimes I can't be sure they're taking good care of the wound. But usually, yeah, only routine.
And for your diabetic patients, Enrique, how long do you keep the post-op antibiotics for?
Only 5 days.
5 days.
Yes.
Do you feel that an endoscopic approach decreases the risk of infection in those diabetic patients? Are you tending to do that in those patients?
Yeah, definitely. There's also a study like last year. It was a multicentric study in Europe, and at the end they were comparing like uniporal versus open microdiscectomy, and for herniations, and they found out that when you do like long-term results in satisfaction and in recovery, the results were the same for both groups, for open and for endoscopy. But in the open group, they had around, it was like 300 patients, and they have around 4 infections or 6 infections. In the endoscopy group, they have no infections, like 0. So although the result was like not statistically strong for those 4 or 6 patients, and for those 4 or 6 surgeons having an infection, I think it's like a really turning point, because you never want to have an infection. So for me, endoscopy has helped me on that, like preventing infections that are really bad scenarios for patients and for surgeons.
But you still give antibiotics post-op?
Yeah.
All right. Well, let's move on to Dr. Bishnu's talk, if that's okay with everybody, unless there's some final comments before we do from this last talk by Dr. Zubair. Dr. Bishnu, you can go ahead and pull up your slides. Oh, sorry, Donald, do you mind pulling up Dr. Bishnu's slides, and then Dr. Bishnu can walk through them? Thank you, Don. All right, Dr. Bishnu, please, the floor is yours.
Okay. Good evening and good morning to all over the world. I'm Dr. Bishnu Babu Thapa, working in Sri Birendra Hospital, Kathmandu, Nepal, which is affiliated hospital of Nepalese Army Institute of Health Sciences. And Cauda-Equina syndrome is one of the emergency condition, and we treat as an emergency, though in literature it's written that Cauda-Equina syndrome incomplete type can also be managed conservatively, but in our center, we treat, irrespective of the stage of the Cauda-Equina syndrome, we treat as an emergency condition and surgery. Next page. Okay. So this is a 36-year-old male patient presented to us with a low back pain for last 2 months with a VAS 7 and urinary incontinence for 10 days, and pain and tingling sensation left lower limb for 1 week with a VAS of 6. On examination, there is decreased sensation on the left side, L5-S1 dermatome, and decreased perianal sensation is impaired, and anal tone also decreased with the ODI of preoperative ODI is 60. And this is an X-ray of the same patient with a looks normal, except there is some loss of lumbar lordosis. Otherwise, X-ray looks normal. So this is a case of back pain with neurological involvement, and the next investigation would be the MRI. MRI is the gold standard. So next, please. Next, please. Okay, this is MRI. MRI is a sagittal and axial section. There is a large disc prolapse at the L5-S1 level. In T2, there is a large L5-S1. There is a large disc prolapse on the axial section. Also, there is a almost all over the spinal canal is covered by the disc fragment. So with this history and this MRI investigation, we came to the next, please. This is a case of Cauda-Equina syndrome due to disc prolapse at the L5-S1 level. Next, please. So, there are various treatment options for the Cauda-Equina syndrome. There are almost all procedures are well-established technique. The first one is a laminectomy and decompression with or without fusion, depending on the stability of the spine. So this is also a well-established technique. And the other one, which is open microdiscectomy, open microdiscectomy or microscopic microdiscectomy, both are well-established. And the other one is minimal invasive microendoscopic decompression also. So nowadays, due to development of endoscope and the other instrument, the surgeons are gradually shifting towards the endoscopic decompression. Though there is a controversy like some surgeons prefer endoscopic and some do not prefer because of inadequate decompression and some neurological damage also. So that's why some do not prefer endoscopic as well. But there are many articles and they have mentioned that endoscopic technique proved to be a safe and effective method for treating cord iconius syndrome. Next, please. So, I did this cord iconius syndrome, or this case with the UV technique, and although I'm sorry that video is not clear, but once I removed the part of the lamina by using a diamond board, 3 mm diamond board, and exposing the neural structure, but neural structure are very tight, so very tight due to large fragment. And initially few fragment I remove in piecemeal, and then usually I do not remove the whole ligamentum flavum. But in this case, because of the large fragment, it is difficult to mobilize the neural structure. So I remove all the ligamentum flavum, and first few small fragment I remove, then neural structure are slightly loosened up. Then I retracted the knob root and dura, and then expose the disc space and gradually try to pull out the large fragment. It is very difficult, and because of large fragment, I'm pulling out this. So once we remove the large fragment with adequate decompression, then some amount of bleeding will occur. So unless and until some amount of bleeding occurs, that means there still some fragment will remain. So I'm trying to remove this large fragment. Yeah, it's coming out gradually. Yeah. I'm sorry that video is slow. Yeah. It's okay. Okay. So I usually do the 3 mm. I use the 3 mm board, and RF is before exposing the neural structure, the coagulation is 3 and cautery is 7. And once the neural structure is exposed, the cautery is 5 and coagulation is 1. 1. So it's a fragment is coming out, large fragment. Okay, now it's came out the large fragment, and there is some amount of bleeding which is controlled by RF. And I usually do the annuloplasty and recheck with the knob hook to see the any fragment still remain or all the fragment came out. So next, please. Okay, this is the last fragment I've removed, and next, please. Post-operatively, the patient, both back pain and low limb pain was improved from back pain from VAS 7 to 3, and low leg pain from 6 to 2, and perianal sensation and anal tone also improved. So next, please. So post-operative, the MRI, we can see both in axial and sagittal cord that well decompressed. And now there is in axial also, there's a well decompressed, and in sagittal cord also, there is a well decompressed at L5, S1 level. Next, please. So when we compare the preoperative and postoperative, preoperatively, there is a large fragment, but here it's completely decompressed. In axial section also, there is a large fragment centrally located. Almost all spinal canal is covered by the disc, but in postoperatively, there is a well decompressed. Next, please. So when compared with the preoperative and postoperative at 3 months, except all the parameters are improved except sexual dysfunction, which is still persist even in 3 months of after 3 months of surgery. Otherwise, all the parameters are improved. In my experience, even in open, which before this I used to do my open microdiscectomy. In those cases also, sexual dysfunction is last to recover, and even in many patients, sexual dysfunction is persist. Next, please. So there are many articles for whether cord syndrome treatment, cord syndrome to be treated with endoscopic or with the open laminectomy or microscope or microdiscectomy. There is both for and against in many literature, but still that with the advancement of the and development of the new endoscope and instrument, this percutaneous endoscopic discectomy is becoming an increasingly feasible and safe surgical technique. So next, please. So with the now the take-home message is with the advancement of the endoscope and instrument, this endoscopic decompression could be a valid option for the treatment of cord syndrome so that we can prevent the complication due to open laminectomy. Thank you. Now the floor is open for discussion. Thank you.
Thanks, Dr. Bishnu. Fascinating case. Don, do you mind going back to the preoperative MRI at the beginning? Just for the images for the purpose of the discussion. And Ike, I'll hand it over to you for your first set of questions.
Yeah. Thank you, Dr. Bishnu. This is obviously a very, very interesting case for all of us. Cord syndrome, again, we treat it as emergency here. And my question to you, and you mentioned this in the beginning of your talk about the reason why people may shy away from doing endoscopic, using endoscopic techniques while managing cord syndrome is difficulty confirming adequate decompression. What are some of the things that you do to avoid an inadequate decompression or to confirm that your decompression is adequate?
Yeah, for obviously there will be a large fragment. So we should not be happy just by removing one fragment, because still there are many fragments still need to be removed. So recheck and recheck is mandatory to be a direct, like complete decompression. That is one of the intraoperative. That is the only thing. And preoperatively assessment also very mandatory. Like in this case also, I removed two fragments first. The one fragment is very large, but again I recheck the inside, and then I'm still in doubt. There is still large fragment still is there, so I could remove the large fragment at the end only. So that is the only thing I think. Yeah, sorry.
No, sorry, Dr. Bishnu. Go ahead. Finish your thought.
Yeah. So once we remove the large fragment, I've mentioned in my presentation also, there will be some amount of bleeding. Anything when we decompress adequately, there will be some amount of bleeding. That is the one of the sign of adequate decompression, I think, intraoperatively. Thank you.
You made that point, I think, very well in the presentation. Sorry, to speak as a non-spine surgeon here, I'm just curious, is there an advantage to doing this endoscopically versus doing it open?
For me?
Yeah, for you or for Rafael also raised his hand. I'm just curious, what was the rationale for choosing an endoscopic approach in this case?
Yeah, before this, I used to do open microdiscectomy, and I was fine with that technique. But recently, I've started this UV technique, and I have this all the open the complication due to open surgery we can prevent with the endoscopic, because this is a saline-based surgery, and rest of the technique are ear-based technique. So the chances of infection is less in endoscopic technique, and other costs also like hospital stay and is less. We can discharge the patient on the same day or the next day. So that's why I choose. I've gone through the literature as well, whether this cord syndrome is treated by the endoscopic or not. But I found there are many articles. There is a case series and comparative study also in this case. So that's why I choose endoscopic technique surgery in this case.
Yeah, thank you. Dr. Rafael, your comments?
The reason why your question is very, very interesting, Kiran, is because we're not discussing a case where it's just a discrimination. It's a Caldecott syndrome, and like it doesn't really matter which technique you use. You should be very comfortable on doing it. And the main reason here why I'm saying that is because it doesn't really matter which technique you use. You should operate it as fast as you can, because it's a Caldecott syndrome. I wouldn't delay my surgery because of a technique because the disposable or not available or something like this. In Caldecott syndrome, and I'm saying that because we have a lot of like fellows in here, we should do what we are most comfortable and what we have in hands, like what are the available options. So this is just one point I would like to address here. This is a very different case from like a simple disc herniation.
And I'm going to take it to another place, and I have not adopted minimally invasive techniques for treatment of cauda and I still go midline open with these surgeries, and my rationale for that is there's a high likelihood that there will be residual symptoms no matter what you do. And in my mind, I want to know with zero doubt that I am adequately decompressed so that if those residual symptoms are there, I am not questioning the quality of my decompression of my work. And so if you, in your practice, are 100% confident that you achieved an adequate decompression with a tubular approach, an endoscopic approach, that's what you have to have. And for me, open is still my approach for cauda equina, because I do not want to doubt that the residual symptoms are a result of me having an inadequate operative result.
I think this ties into the point that you made earlier, Jason, that you should always be very aware of your own skills and perhaps your own biases before doing any surgery. So I think that's a really important teaching point for all the juniors out here who may be inspired by Dr. Bishnu, but should be aware of their limitations before jumping into something. I think that's a very important point. Yeah, I think there were some other comments here in the chat. I don't know how you wanted to weave them in.
You know, I think one of the things that stood out to me actually is that you had a post-op MRI. And I guess one of the questions Dr. Rizwan also asked in the chat is, when did you get that MRI? Why did you get the MRI? Is that part of your protocol to get an MRI after anybody has cauda equina? Dr. Bishnu?
That post-operative MRI I did after 1 month of surgery, and this is totally for academic purpose only.
Okay. Right.
Otherwise, patient is symptomatically better, except his sexual dysfunction is still was not improved, but still not as previous. Otherwise, rest of the symptom were improved. So I did MRI just for academic purpose.
And to Jason's point, that's fairly common after cauda equina, I assume, that sexual dysfunction or some other aspect will be long time coming back. Jason, thoughts?
Yeah. Well, and also this gentleman presented 10 days in, if I remember correctly from the history and physical. He is well outside the window of an acute cauda equina where you're looking for that 24-hour window, no more than 48 hours. But the literature is very clear that your best chance of recovery, and I emphasize the word chance, is within that initial 24-hour window. And this gentleman presented greater than a week out. And so these patients, this is not a patient I rush to the OR in the middle of the night because they're not in that 24 to 48-hour window. I still treat them urgently, but it is not an emergent case at this point.
That's a clear learning point. Thanks, Jason. Rizwan, did you have any comment on this case?
No.
Okay.
All good. I agree. Totally agree with Jason. Yeah.
All right.
We still prioritize to do open in cauda equina and do it emergently in cases presenting late. But if they are in a window of 24 to 48 hours, it's an emergency.
Yeah. There's a comment here from Zubair Khalid about ULBD. Is it appropriate in cauda equina syndrome, or only removing disc is enough? Yeah, Bishnu, go ahead.
Yeah, I fully agree with all the faculty that this should be treated as emergency, irrespective of the type of the surgery, whether it's micro or open or endo or micro endo, whatever technique, it should be done as soon as possible. But in my country, usually the patient present late. It's very difficult to come to hospital within 24 hours or 48 hours. Usually patient comes out after 5 or 7 days. And even in earlier days, I have experienced that even after 7 or 10 days of surgery, the patient neurology was completely recovered. I don't know, it's contradictory to literature, but in practically speaking, it's even in late presentation, if we do surgery as early as possible, the neurological recovery is expected well.
That's another great teaching, Bishnu. Thank you. And I guess it also has to do with the adequacy of your decompression, right?
And I will say that UBE, probably in my mind, out of the endoscopic approaches, is probably going to be the better one for a cauda equina, because you're still going to do that wide midline decompression, more so than what is traditionally taught for the uniportal. The uniportal is really taught as a bone sparing, anatomy sparing approach. You can still, if you are advanced and comfortable in your uniportal approach, do an aggressive bony decompression. It's not to say that it cannot be done, but it's typically not the initial training in the uniportal world. But biportal, you can take down the base of the spinous process, come across the top, take down the contralateral lamina. So you can get the decompression. It just, again, don't be so fixated on how you do it. Just be fixated on doing it well. And if you cannot do it well, or you question your ability to do it well, down a tube with endoscopy, open it up. There is zero shame in opening a patient with this presentation.
Yeah, thank you, Dr. Pittman. That kind of leads us to another question in the chat from Shazad. They comment cauda equina syndrome is a spine emergency, needs adequate wide decompression to give the patient final chance to recovery, like urinary incontinence for 10 days in this case. What counseling points do you consider for cauda equina surgery? And if I might add to that, Dr. Bishnu, how do you counsel your patients if you're, if in your hands, you feel this is, that you can accomplish the results of the procedure with endoscopy versus the other option to have an open surgery? And then how do you give the patient the information about the risks and benefits, and what are the big things that you highlight there?
Yeah, now first thing is the patient usually present late in our part, usually present late. So those who presented late, usually we counsel that the complete neurological recovery is only 50% chance, or may not recover completely if they present late. And regarding whether the open or endoscopic technique, irrespective of the technique, the decompression is important. If adequate decompression, it doesn't matter what technique you are doing. So I always counsel, not only in cauda equina, in every endoscopy, in every case, I usually counsel the patient, I do endoscopically, but if fail, I do open. So I take the consent of open in every case. Thank you.
Thanks, Dr. Bishnu. Fascinating case and great discussion. Just for the purposes of time, I have to sort of push us to move to the final case. If there are some final comments here, especially from Enrique, I'm sorry if you had a comment.
Don't worry. No, I think it's all well said by Dr. Pittman and Dr. Bishnu. It's just do it as well as you can and with the tool you have at hand. Maybe for the other case, but I will have a question for the faculties here. If it's not like a cauda it's only a disc herniation, how do you treat the disc? Because I've seen cases when the experts just go inside and just burn all the disc inside, trying to decrease the risk of reherniation. And some other just take the piece that's herniated, which is what I do. And how aggressive are you with the remaining disc?
I fish. I don't go in with the, say, the RF probe and burn it. But I go in with a curette and gently probe or a nerve hook and follow up with multiple passes of a micropituitary, really looking for those those potentially loose free fragments. And the rate of reherniation in my experience has been low. And you're starting to see more and more of these annular repair devices come back, and this is not a new concept. I mean, it's decades old concept. But you're solving a problem that's not really a problem.
Yep.
Rafael, a comment?
So I also tend not to be too aggressive in disc, and for me the main point is when you have like literature says that if you have a annular defect less than 6 millimeters, the reherniation rates are like around 1%. So I try not to be aggressive because of that, because sometimes you have a very small annular defect and you create a larger hole. That's my main reason. You turn a patient that has 1% risk to a patient that has now 27% risk of recurrent sciatica or reherniation. So because of this, I tend not to be too aggressive unless you have a very big disc herniation, then a big annular defect. Then I tend to be a little bit more aggressive. But in most cases, I try just to do like surgery like Jason does, like just try to remove like free fragments and try to preserve anatomy the most. And that's the literature I use. It's the Carnegie perspective for microdiscectomy. He measured the annular defect and had this result, and it's very different. If you have less than 6 millimeter, you have a reherniation or recurrent sciatica at 1%, and if you have a larger defect, more than 6 millimeter, the recurrence rate goes up to 27. It's a huge difference.
Dr. Rizwan, final comments?
Yeah. If the disc fragment is spanning through the annulus and there is a hole after removing the fragment, I go in and remove the disc fragments, find them with the probe and use a forward and a reverse pituitary. And if you remove the fragment and there is no, you create any hole or a tear in the annulus and it's healed, so then I leave it like that. So this is what I do.
Thank you.
Thank you all. Great discussion. We're going to move on to our fourth and final case, Dr. Umair. You can go ahead and pull up your slides.
Umair, are you able to pull up your slides?
Yeah, I'm going to share my video in a second.
Okay, great. Thank you.
I think something's wrong. Can you pull up my presentation for me?
Sure. Don, do you have it? Oh.
I think I'm up. Can you see my screen?
We can, but it's only the screen recording warning. John, do you mind pulling up Dr.
Yep.
Umair's slide?
Oh, maybe you got it.
There we go. Great.
Or we can see your screen.
Oh, all right. Hi, I am Dr. Umair Ahmed, and I'm a orthopedic resident working at Purki Trust Teaching Hospital. And I'm very obliged to present a case at this platform. So I'd be talking about the minimally invasive transforaminal lumbar into body fusion. And I'd be talking about a female, 49 years of age with multiple comorbids. She presented to us with lower back pain, which was radiating to the left leg, and her symptoms were associated with paresthesia and tingling. And on her first visit back in 2022, her VS at the lower limb was around 7, and the back was around 2 with the ODI of 65. This particular patient had the SLR of 90 on the right side, whereas left side was 50 with intact motor and the sensory systems, and her bowel and bladder was intact with no perineal numbness. This is an X-ray showing the dynamic X-rays of the women with the lumbosacral X-rays AP and the lateral view showing adequate disc space and no signs of instability. But on her preoperative MRI, this is a axial section showing the left-sided paracentral disc, and this is a sagittal view showing the disc herniation at the level L4 and L5. So we decided to go for a minimal invasive disc excision, for which we chose a tubular system. This is a intraoperative image showing the fecal sac, the root, and the disc space, from which we were able to retrieve a large disc. So post-operatively, the patient was fine. On the first post-op day, she was pain-free with the VS of 5 in the lower limbs and the VS of 2 in the back. And she was sent back home, and on 6 weeks follow-up, she was doing well. But then after 2 years, she presented to our outdoor unit with the similar complaints with which she presented 2 years ago. So this time, the SLR was still 60 degrees and the bowel and bladder was intact, with significant increase in our VS score of the lower limb, which was 8. We did a MRI after 2 years of her a red disc on the left side on both of these T1 and T2 weighted axial images, and similarly the disc was visible on the sagittal sections on L4, L5 with mild end plate changes. So since the patient had a significant lower back pain along with the radiation, we decided to go for a unilateral biportal endoscopic disc excision. And this time we were able to retrieve the remaining segments of the discs, which was left initially. So this patient presented to us. On the first post-operative day, she was fine, and on the 6 weeks follow-up, she was doing well. But then again, she presented 4 months after the UBE disc excision with a similar complaint, with the ODI of around 74, 75, and her VS was 5, the lower limb, and VS at the back was around 7, and the SLR on the left side was 50. So keeping in mind the chronic lower back ache with prior failed discectomies, we had to choose a more targeted approach for this patient. So we did a X-rays to see if there was some signs of instability, and we could see that there were at L4, L5, and then we had to do a post UBE MRI, which was showing disc L4, L5 disc causing compression of the thecal sac with along with the modic changes which were visible at the lower end plates of the L4 vertebrae. So this time we chose for a more targeted approach for her residual disc, which was minimally invasive transforaminal interbody fusion. And this is an image showing the percutaneous placement of the transpedicular screws. And we did a interbody fusion with a cage, and this is a post-operative X-ray showing the transpedicular screws in both L4 and L5 with a interbody cage. Subsequently, the patient post-operative was on the first post-op day, she was completely pain-free. And then she went back home on the second post-operative day. And then on 6 weeks follow-up, 6 weeks, she presented to our outdoor with literally no lower back ache, and she was mobilized. Her ODI was around 20-24, with the VAS was 2 in the lower limbs and in the back. So that would be it, and I'm open for questions.
Thanks, Umair. Can you go back to your preoperative slides?
Sure.
And Rizwan, maybe you can take the first stab at commenting on this case.
Yeah, I think this patient had a sacralized L5 with the large transverse processes, and there was minimum movement at 5S1. So the major segment which she was bearing a weight, it was 4-5. So I think that could be one reason of having a residual disc and this disc disease at this level. This is one adding point into it. If you see the X-rays.
A question for Dr. Umair or Dr. Rizwan, pre-op before the first MIS disc excision, do you get flexion extension films? Was there any sign of instability? And if you do recognize that somebody has a sacralized lumbar vertebrae, is that a relative contraindication for you to do endoscopy or any endoscopic techniques versus a more open procedure?
No, I think first surgery, she remained well for 2 years. So, and at that time, there were no changes on the end plates. So we cannot make a rule that we do a fusion in all cases having this type of X-rays. So yes, I think principles remains the same. Yeah, Jason.
Dr. Pittman, comments?
Yeah, so I agree, and I just raised my hand because the question that just popped up in the chat, and the best advantage in my mind of endoscopy for minimally invasive fusion is because you can actually drive the camera into the disc space. And you can watch your discectomy, unlike what we do when we do open or MIS TLIFs, where, there are plenty of studies that show that we only get out, 25-30% of the disc when we think we've done an amazing discectomy. And so when you watch video of an endoscopic fusion, it's amazing because you can go in with a shaver and get down to nice not decorticated, but bleeding end plates with the true resection of the fibrocartilaginous end plate. and get the entirety of the disc, almost like you do when you do a lateral or OLIF approach. And that's the true advantage of the endoscopy perfusion over open. And then with regards to, I love minimally invasive approaches for revision discectomies because it is easier for me to get through the scar tissue and identify the previous surgical bed without the concern of falling into it accidentally during my approach. And then the people that are really experienced with endoscopy argue in favor of hydrodissection of the scar bed, where you don't have to do the sharp dissection with curettes or other. You can really take advantage of blunt dissection with the water pressure to get through the previous surgical bed. So there are a lot of advantages of the MIS techniques for revision surgeries in this case.
There's a great question in the chat actually from Santiago Montenegro asking, part of the success in interbody fusion relies on the rate of bony fusion integration around the implants. What are some techniques that you can do endoscopically to favor this process?
Drive your camera into the disc space and visualize the entirety of the discectomy.
Rizwan,
Is there anybody on the line that's using endoscopy during their fusion procedures?
Yes, I go into the disc space with the camera, and fewer times we use a shaver even to remove all the fragments and wash that area and to see the end plates bleeding. And once you see the disc space, and the end plates, they have a good, for the fusion. And even to the other side, you can see the contralateral side till the contralateral side through your camera in the disc. And once you have seen it, wash it, and then you can put a graft and the cage in. That favors the fusion.
Fascinating. Just I want to, sorry, I wanted to jump in and say 5-minute warning for last sort of comments before we wrap up the session.
How is using some of the endoscopic technologies in your fusion procedure changed like your operative times, your outcomes, Dr. Rizwan?
Actually, you have, first of all, you have to be weak. So start with the disc, and once your time has, you have decreased your surgical time, then you go for a fusion techniques. And believe me, if you start doing fusions with the scope, you see everything which you cannot see even with the microscope. I used a microscope. So the view of a microscope from the top, you are looking down, and with the camera in, actually you are looking, so your eye is actually inside and you can see all the preparations, and it's more safe. Whatever you do, if your camera is in and your view is very clear and it's a 4K HD view, and it's a big view, so that actually improves and increase the safety. Jason has raised the hand.
The deeper the patient, the more valuable the endoscopic approach. For those that are here that have used tubes before moving to endoscopy or continue to use tubes, once you're down a tube deeper than about 70 millimeters, the technical challenge of that case is dramatically increased. And anybody that's done a case down a 100 millimeter tube that ends up being 130 to 150 deep by the time you get to the disc, it's a nightmare surgery. So endoscopy is the equalizer when it comes to it. It's the same technique, and we just get back to the worst part of endoscopy, and that is your portal placement.
There's a comment in the chat from Zubair. Zubair, do you want to ask your question live?
Yes, sir. Sir, my question is that if there are modic changes are present at the end plates of the vertebra, then what are the points favoring for we go for the first time fusion technique, or we go with the only the dissection? If there's a modic changes type 1, type 2.
Any comments from the faculty?
I don't rely on modic changes to indicate fusion. In fact, I don't even comment on modic changes when I review imaging and discuss it with patients. I think it's useful for the radiologists, but I don't find clinical value in the discussion of it. And, my decision making is based on symptomology more so than the radiographic findings.
Sir, then if the patient has one time recurrence of the disc and second time patient presented us again with the same symptoms after some time of 1 year or 2 years, and there is a slight sclerosis at the ends of the disc of the vertebral ends, then it's wise to go at the same time fusion, or we can go with this non-fusion techniques.
I have the conversation with the patient and, go through the two options, revision discectomy versus fusion. I think the gold standard, or at least the standard of care in the US, is still microdiscectomy for an initial recurrence. The third recurrence is a fusion.
Yes.
However, I just had a patient that had a recurrence of herniation about 7 years after her initial discectomy. And we did a revision microdisc, and then she had a recurrence 3 months later when working with physical therapy. And we had the conversation fusion versus treating it like an initial recurrence, since she was so far out from her original, and she's 30 years old. And she opted for another revision discectomy, knowing that her next surgery is a fusion no matter what.
Thank you, sir.
All right, guys, for the interest of time, I'm so sorry to do this. Going to have to wrap up. Really great conversation today, and really appreciate all the comments from the faculty. I guess we have just a few moments for closing thoughts, particularly from Ike and from Enrique. If you guys have any final teaching points you wanted to share with the audience before we wrap up.
So I think these were all valuable cases, and this is just like an introduction on how to take care of patients with endoscopy. I think the most important thing that we talked about is to use it as you can. Know how far you can go with your skills to treat a patient, and when you have to do some other techniques. Like I think Ike said at first, it's just a tool we have in our arsenal, and the main point is to give the patient a solution to their problem. If you're more comfortable with one technique or the other, and you have a perfect end result, that's the way to go. But as a tool that's becoming more popular and it's having any more options to apply, I think it's really important to get into it and try to learn it, because there's certainly proven advantages than over other techniques. And I mean, it's an exciting technique, and it's right to get excited, but you need to have the training and the knowledge just to start doing it.
Great point, Enrique. Absolutely. Ike, any final comments?
Yeah, this was amazing. It's amazing to hear the views and the thoughts of everybody around the world. Thank you, everybody, for joining. like Enrique and everybody has highlighted, endoscopic spine surgery is exciting. It's new. I think a lot of people are incorporating it as a trainee. It's exciting to hear the different ways it's incorporated. We talked about a number of pathologies today, from disc herniation to using it to treat cauda-equina syndrome, to revision surgery and its utility in fusion surgery as well. So an exciting time we're in, and I'm very thankful to learn from you all.
Thanks, Ike. And then the last point I'll make here is also it's very inspiring to see these technologies now being used in resource-limited settings as well for the care of patients. And the advantages that Enrique just gave for endoscopy are equally applicable in a resource-limited setting. So it's wonderful to see this technology adopted and the pioneering efforts of the surgeons who presented today. So thank you. All right, well, with that, I'll close out the session by saying thank you to all of our presenters and our faculty. It's always a wonderful experience engaging in these conferences with you guys, so thank you so much. A reminder to all of our participants, we have certificates of participation available if you attend all 3 sessions and complete the pre and post surveys for each session. So the post-session survey for today's is available through this QR code, and Dawn will share all the links in the chat now as well for all of you to click on. And please do give us feedback. We find the feedback extremely helpful. In fact, all of the topics that we've chosen to go over for this conference were actually suggested by participants who gave us these their interests in our exit surveys. So please do take the time to give us feedback. We really do appreciate it. This is just, as we talked about, the tip of the iceberg. There's so much more to talk about when it comes to endoscopic surgery or spine surgery in general, especially when dealing with resource-limited settings. And so we've created an online community with lots of WhatsApp channels available for any of you who would like to join. Please do consider that. And the link for that will also be posted into the chat. The entire curriculum for this course, the pre-recorded lectures, including by many of the esteemed faculty on today, including the recording from today's session, everything will be posted for future reference on our SONA Global Academy website. And thank you for joining us today. And I'll leave the line open for a few more minutes in case there's some lingering questions, but we'll close out the session there. Thank you all. Really do appreciate your time.
Thank you, Kiran.
Thank you very much.
Thanks, Enrique. Thank you.
It was a learning, it was a mutual learning. I learned a lot.
Thanks
from all of you. Thank you very much. Thank you.
That's wonderful. Thank you for that. That's what it's all about.
Yeah.